Hello and welcome to Season 2, Episode 45 of the Physician Assistant Exam Review Podcast. This episode, we're going to continue with dermatology and infections of the skin, in particular, a couple of different viruses we need to wrap up with. My name is Brian Wallace. I'm the host and creator here at physicianassistantemexamreview.com. You can find all of the notes over on the website. Also on the website, you can find the email list to go ahead and sign up there. I can't recommend that strongly enough. That's where you're going to get all the tips and tricks. I send out daily emails with all kinds of great information in there on how to do better with test taking, how to do better with studying, and on and on and on. In addition to that, coming up, I'm going to start adding a little bit more into that, and I think you're going to want to be part of it. So go ahead and make sure you get on that. If you're not already in there, go ahead over to the website. It's really easy to get signed up there, but that's where a ton of information comes through. So anyhow, let's see. This week we're going to be continuing with dermatology. So what I want to do to start is really just go ahead and jump right in. Name 3 risk factors for genital warts. Name 3 risk factors for genital warts. A skin sample with multinucleated giant cells should make you think of what diagnosis? A skin sample with multinucleated giant cells should make you think of what diagnosis? A wrestler with flesh-colored, dome-shaped, umbilicated lesions should make you think of what diagnosis? A wrestler with flesh-colored, dome-shaped, umbilicated lesions should make you think of what diagnosis? And what's the treatment for shingles? What is the treatment for shingles? All right, so back again, running into dermatology. And in this case, we're covering infections of the skin, some specific viruses that didn't fall into the other categories. So we're going to clean them up here. Condyloma acuminatum is first, which is anogenital warts. Condyloma acuminatum. These are warts found typically in the genital or anal area. Pretty clear. Human papillomavirus HPV type 6 and 11. These are sexually transmitted and very contagious, especially when the warts are visible. Risk factors here include sexual activity with multiple or high-risk partners, immunosuppression, and smoking. The clinical presentation is the external warts may have a varied appearance. So they're not always going to look the same, right? So you get a single or multiple lesions, depending. They can be flat, they can be dome-shaped, they can be cauliflower-shaped, they could be white, they could be flesh-colored, they could be red, etc. So the test questions are going to be sort of awkward here as far as the description of the lesion goes. They don't have much to give you to point you to condyloma acuminatum based on the description of the clinical presentation of the wart itself, right? So you have to come up with some other indicators when you cover these questions. So is the patient smoking? Is the patient have immunosuppression? Is the patient at high risk due to sexual activity? Those sorts of things are what you're going to be looking for in the stem of the question that are going to point you to this diagnosis. Obviously, it can't really be the description of the wart because they have multiple different descriptions. So think about that as you review any question that's going to include condyloma acuminatum in an answer choice. Treatments. Well, first of all, prevention is going to be better than treatment. Safe sexual practice is number one. There's also the HPV vaccination now. Gardasil protects against HPV 6, 11, 16, and 18. 16 and 18 are the ones that are linked to cervical cancer. And what did we say? 6 and 11 are the ones that are linked to anogenital warts. The goal of treatment is a wart. Sorry, I got ahead of myself there. So you want to prevent it. That's goal number 1. Goal number 2 is once you have it, is wart-free periods of time without scarring. So you're not really going to clear it necessarily, but what you can do is decrease the inflammation. So there's no real cure, but there's lots of different treatments. And that always, to me, means that nothing really works well. It's kind of like baldness cures or cures for plantar fasciitis. You can look them up online, and you find hundreds or thousands of different things that'll help you clear up your plantar fasciitis, which means they all sort of stink, which is the reality of it. You have to try lots of different things. Sometimes they work, sometimes they don't. So I run into similar things here. There's lots of different creams out there. You can do laser removal. You can do cryosurgery. But you're not really going to clear it forever. You're just going to try and treat the active warts. Next, we have herpes simplex, which is virus type 1 and 2, are the main culprits here. And it's often said that type 1 is oral herpes and type 2 is genital herpes, but there's a lot of overlap. I don't think that's going to be all that helpful. The clinical presentation, this is small groups of vesicles. So see how that's a much more clear clinical presentation? Small groups of vesicles versus condyloma acuminatum is single or multiple lesions, flat, dome-shaped or cauliflower-shaped, white or flesh-colored shape. That's not really that helpful. For herpes simplex, it really is clear. It's small groups of vesicles. They're typically found at the vermilion border or in the genital areas. I think in like a cold sore. That's how it looks. They're usually painful neuralgic symptoms, including burning and itching. That can happen before you see the lesions. So you get this severe burning pain near the lip, and oftentimes that's going to be herpes, that neuralgic pain. Variations and complications. So there's a couple different places that the herpes virus can affect the skin. So you can get herpetic whitlow, which is infection of the fingers. You can get herpes keratitis, which is an eye infection. You can get herpes encephalitis, which is a CNS infection, and neonatal infection, which is active herpes infection in the mother, as an indication for a C-section. So if mom has genital herpes and she's about to deliver, you don't do a vaginal delivery. It's an indication for a C-section. Labs and studies, this is a clinical diagnosis. Stains of the vesicles will show multinucleated giant cells, and there is an antibody test available. Treatment here, same problem with a lot of our virus issues. There's no real cure. You want to kind of manage the symptoms and keep the flare-ups to a minimum and as short as possible. So typically the flare-ups are self-limiting, but you can use topical antiviral 5% acyclovir. That tends to not work as well as the oral antivirals, which is acyclovir and valciclovir in this case, but those are really expensive, and most insurance companies aren't going to want you to go that route. You can also use Tylenol and ibuprofen to manage the pain. These can be painful. That burning sensation can really, really bother people. And again, be aware, because you may not see the vesicles, and this isn't going to be a test question, but in practice, you may not see the vesicles, and the person comes in just complaining of severe burning pain around the lips, and you should be thinking about a herpes infection. Our next one for today is molluscum contagiosum, which is a common skin disease caused by a virus, which is what we're doing today. And it's easily transmitted by sharing towels or clothes or from wrestling or gymnastic mats. The clinical presentation here is flesh-colored bumps. So we have a color, right? So they're flesh-colored. So that helps us. They tend to be dome-shaped, pearly or waxy, umbilicated, and not painful or pruritic. Right, so you always want to be thinking about how we can separate these things in your head. So herpes tends to be painful and pruritic, right? So it should be easy to tell apart molluscum contagiosum and herpes. That shouldn't be hard. The umbilicated part, for some reason, has always stood out to me and made this a really easy one for me to get right on test questions. They always talk about a dome-shaped umbilicated lesion on the test questions. That should be super easy. You should be excited to see that. Labs and studies, usually a clinical diagnosis, and the biopsy will confirm it if you really want to. Treatment here is going to be, it's usually self-limiting, but may take up to 18 months and is contagious while the lesions are visible. You can remove the lesions, and there are many different ways to do it, again with a laser, cryotherapy, or certain creams. Chickenpox, varicella. So this is human herpes virus 3. You get a primary infection, leads to chickenpox. It's contagious if you touch the vesicles or by respiratory droplets. It is contagious for several days before the lesions appear and up until all lesions have crusted. So if you have a kid who's been around someone who breaks out in the chickenpox, anybody who's been around him for a couple days beforehand is susceptible. Remember, these come out in waves, right? So you get some lesions that appear and then crust, and then new lesions appear and then crust. So the person's contagious until all the lesions have crusted over. And this is also interesting to me. There's a 14 to 21 day incubation period. So you may have a kid who's been around someone with chickenpox, but it takes up to 3 weeks before you would realize it. Clinical presentation, usually a child younger than 10 presents with severely pruritic lesions. Again, I think that's one that we're all familiar with. Initially, these red macules and papules, followed by vesicles, which after a few days crust over. And that's your dewdrops on a rose petal. I don't know how helpful that one's going to be. I mean, that to me, that's the key term that goes along with chickenpox. And you might see it, but it's just a sort of a helpful description. You have the red background with that vesicle and that fluid on top of it. It's more for keeping the idea in your head than that's the type. And this is what kind of one of the things that drives me nuts is this is one of the key terms. And people are like, oh, I'm not going to see that on a test. Well, no, you're probably not going to see the term. It looks like a dewdrop on a rose petal. I agree that if that shows up on your exam, then there's probably something wrong with the exam writer. But it does paint a picture in your head of what the lesion looks like. And that's what they're trying to do with this type of key term, with this type of description. No one's saying you're going to see that on your test. What they are saying is, if you've never seen it before, this is a way to describe it. So then when someone comes along and says, oh, there's a red lesion that came and then has a little vesicle on it, and it's really itchy, and you can see the little drop of fluid on the top, that kind of thing. And that should gear you or cue you in to think, oh, the dewdrops on a rose petal was the description for chickenpox. Maybe we're heading down that road, that kind of thing. It should cue you in to hold those descriptions in place. It's not going to show up on your test just written like that. As I was saying a couple of minutes ago, the lesions appear in crops. So that means you get a certain number of lesions on day 1, then more appear on day 2, and then on day 3, et cetera, et cetera. All the lesions then are in different phases. The lesions from day 1 may be crusting while new lesions are appearing on day 3, right? So again, you have to wait till all the lesions have crusted over before the person's not contagious anymore. The rash appears centrally and moves out to the extremities. And then also, in addition to those things, the other reason why you should be able to easily pick out chickenpox is because the patient gets fever and general malaise along with these super itchy macules and papules. Labs and studies is really a clinical diagnosis. It's not that tough to call. But fluid taken from the vesicles and prepared with a zinc smear will show multinucleated giant cells. Treatment. Supportive care here is really the number one thing. You just want to make sure that they're managed well, especially as people get older. They can get really sick. So you want to make sure they've got fluids, that kind of thing. Do not give kids under 19 aspirin because of Ray's syndrome. I'm not going to go into detail there. Prevent or treat secondary infections. So they can get infections from scratching at the lesion. So you want to prevent and then treat secondary infections if you need to with antibiotics. Antivirals may be appropriate in the immunocompromised. And there is a live attenuated virus as a vaccination, and it's always given twice. Now, part 2 here is shingles, right? Or herpes zoster, a secondary outbreak of the human herpes virus, varicella zoster. The virus remains dormant within the nerve cells. So this took me a while to get my head wrapped around. It's one of those things, but I think it's kind of cool. So when you get the chickenpox, your body fights it off, and your immune system is awesome and fights off this virus, but the virus is really good at hiding, and it hides in your nerve cells. And your immune system sort of either forgets about it or continues to battle it quietly, but never fully wins. And normally the immune system keeps the virus suppressed. But certain factors like aging and stress can lead to a new outbreak. So it's the same reason, like the herpes virus, you never completely clear it. And most of us know that when you are stressed out, you get a cold sore. Well, this is why your immune system kind of weakens just enough to let that virus come back and present itself. And then your immune system kind of ramps it up and takes out the virus and knocks it way, way, way back, but it doesn't quite clear it all the way. And that's what's going on here. The clinical presentation for shingles, this is severe burning pain that begins before lesions are visible. That's important. People come in and that severe burning pain that absolutely kills. Like they can't even put a shirt on. They can't go anywhere near it. They can't put sheets on if they're in bed. And that happens before the lesions appear. Then you get this vesicular lesions, which look a lot like chickenpox, and they typically only affect one dermatome, so one nerve root. Hutchinson's sign is a lesion at the tip of the nose, indicates possible involvement of the eye. That's really, really bad. Obviously, you don't want shingles in your eye. Can lead to some bad complications. So Hutchinson's sign is a lesion at the tip of the nose, which indicates that the eye may be affected. Labs and study, again, this is a clinical diagnosis, but you got to be pretty on the ball to grab this one because, again, those lesions usually haven't appeared yet when the patient comes in. And they talk about this as an older person disease, I guess that's the right word, as something that affects older people because your immune system weakens a little bit here and there. But I have 2 good friends who, one in their mid-20s and one in their early 30s, had pretty bad cases. So I know that's anecdotal evidence and it doesn't help a whole lot, but I would, especially in your practice, I would keep an open mind on that one. Treatment is oral acyclovir or valcyclovir for 7 days. And that brings us to the end of our dermatology infectious discussion. So what I want to, before we wrap it up for today, I want to just talk quickly about one of the things I do that really helps me to stay focused when I'm studying. And that's, I have what I'm calling a worry notebook. So when I sit down to study, when I sit down to get work done, when I sit down to write emails, whenever I do any of that kind of stuff, I always sit down at my desk and next to me I have a notebook open, or at least a sheet of paper. And what I do with that is anything that comes up that may be distracting, anything that needs to be worked on, any ideas that pop into my head, go down on that sheet of paper, go into that notebook. And the key to that is I don't bounce all over the place when I'm working. So if I'm sitting at my desk and I'm writing, and I realize, like I did this morning, oh, my son has running club today, they moved it. Rather than spend the next 20 minutes trying to figure out what I need to do, I just write down running club. And then when I'm done, I'll look at it. Or if I remember that I need to take the garbage out, or I get an idea for the next email I want to write, or the next show I want to produce, I just jot that down on that piece of paper. That way I have the information. And the key to that is, as long as you check that when you're done, your brain is convinced that you will do something with it. So that information will stop popping up in your head. If you try to just ignore it, it will continually pop up and recycle as you're trying to get your work done, because your brain is trying to remind you of something it doesn't trust you to remember the way you think you will. But if you put it down on paper and you trust yourself that you'll look at that paper when you're done, your subconscious will let that go and allow you to focus on the thing that you're working on. And I found this to be incredibly freeing and a great move to keep me focused and on one task. It's so easy to sit and study and then look something up and then wind up on a different website and then think maybe I should just check my email. Oh, I was supposed to get an email from someone. Let me look at that. I just jot all that stuff down and make sure at the end of my 30 minutes, I have a little list of things that'll take about 2 minutes, maybe 3 minutes to clear up. But if I do them during that session, I lose a lot of valuable time. And if I don't do them during that session, I still lose that time because my brain is churning over and over trying to make sure I remember those things. So that worry notebook really does a lot to keep you focused and on task. I think that's a really great way, especially if you have trouble staying on task and you find yourself bouncing from thing, to iron that out. All right, so let's finish up with our priming questions for today and give you some answers in case you didn't pick them up as we progressed through this section. Name 3 risk factors for genital warts. 3 risk factors for genital warts. Come on, take a minute, think about it. Sexual activity with multiple high-risk partners, immunosuppression, and smoking. A skin sample shows multinucleated giant cells. What diagnosis should you be thinking of? Herpes was one, and the other was chickenpox. A wrestler with flesh-colored, dome-shaped, umbilicated lesions should make you think of what diagnosis? Again, to me, that dome-shaped, umbilicated lesion just jumps right off the page. Molluscum contagiosum. What's the treatment for shingles? What's the treatment for shingles? It's oral acyclovir, times 7 days. All right, great. So we're moving right through dermatology. Fantastic. I'm so excited to have you guys here with me. I know it's been a little bit of a gap. I don't know if you're listening to this in the future, maybe you didn't notice. Baseball season picks up in May. And I think this week, for a fact this week, we've got games Wednesday, Thursday, Friday, Saturday, a doubleheader on Saturday, and then games on Sunday. So I get a little behind every single April and May. I'm going to try and pick that up a little bit this May and do a little bit better than I did in April and get these out to you because I absolutely love doing them. It's so much fun, and it's fun getting the feedback and hearing from everybody who's doing well and passing and all the things happening with you guys. So please keep that up. I absolutely do look forward to doing these, and I apologize for the slight delay there that occurs every April and May. So we'll pick it up and continue from this point forward, and hopefully you'll be able to keep up without a problem. Anyway, any of you taking your exam this week, good luck. Definitely let me know how you make out. I love to hear both success and failure stories because I think you need to get that off your chest a little bit and share it and put it out there. So definitely let me know how that goes. And until then, I will see you next time.